Well, good morning and good evening, everybody, and welcome to today's webinar. This is part of a weekly series of webinars sponsored by the Center for African Studies at Harvard University in partnership with the Africa CDC. My name is Wafaie, Fawzi, and I'm Professor of Global Health, Epidemiology and Nutrition at the Harvard T.H. Chan School of Public Health, and I will serve as moderator for today's webinar. On February 14th, about 7 months ago, Africa's first case of COVID-19 was reported in Egypt. Today, approximately, Africa has 1.5 million diagnosed cases of COVID-19 and about 36,000 deaths. These were the numbers you have seen in the slide just before the beginning of the webinar. However, there are wide disparities in the scale of infections and in the response to the pandemic across the region. In this webinar, we hope to explore the current state of the pandemic across Africa, the disparity between countries, and the ongoing efforts to address this global challenge. Before we begin, I just have two housekeeping rules, if I may. First, after we hear from the panel, we will open the floor for Q&A from participants. Please add any questions that you may have in the Q&A part of the Zoom or the Zoom function. And second, this webinar is being recorded, so we will have a chance to share it with everybody who has registered, as well as with others. We will post it on our website at africa.harvard.edu. So we'll have an opportunity to disseminate the discussion really far beyond those who were able to join us today. We have three distinguished colleagues as panelists, really fortunate to have them. They need little introduction. Each of them has been actively leading the charge in their respective domains. So I'll be brief. First, delighted to have Dr. Agnes Binagwaho. She is the Vice Chancellor of the University of Global Health Equity in Rwanda. A pediatrician by training, she has provided clinical care in the public sector and served in a number of leadership positions, including as Permanent Secretary of the Ministry of Health in Rwanda and subsequently as Minister of Health. And yes, is also a senior lecturer on global health and social medicine at Harvard Medical School, and is a senior advisor to the Director General of the World Health Organization. Next, Dr. Salim Abdool Karim is a professor of global health and epidemiology at Columbia University, and a director of Caprisa, a center for AIDS research in South Africa. Salim is an infectious disease epidemiologist widely recognized for his research contributions to HIV prevention and treatment. He is also a Pro-Vice Chancellor of Research at University of KwaZulu-Natal in Durban, South Africa. And I'm delighted to note he is an adjunct professor at the Harvard School of Public Health, among his many other responsibilities. He also chairs the South African government's advisory panel on COVID-19. And last but not least, Dr. Nkengasong, a leading virologist with more than 30 years of experience in public health. John is the first director of the Africa Centers for Disease Control, Africa CDC. He was appointed in November 2016 and has been leading the continental public health response to COVID-19. Prior to his current position, John served in several senior positions with the US CDC, first in Abidjan, Cote d'Ivoire, and later for several years at headquarters in Atlanta. He has long-standing experience in leading major public health efforts around the African continent. So welcome again to our panelists, and I'm delighted to note the high turnout for this event. Welcome to all who have registered for the event and those who are currently online. So let us start with the current state of the pandemic on the continent. Africa has managed to keep its COVID-19 caseload and death rate far below the most optimistic projections at the outset of the pandemic. In April, the UN Economic Commission for Africa estimated that anywhere from 300,000 to 3.3 million Africans could lose their lives as a direct result of COVID-19. As we know, the current estimate is at 36,000 deaths. Still regrettable, of course, but far below the projections. Yet there are clear disparities between countries and across the region. Of the more than close to 1.5 million cases in Africa, about half have been reported in the Republic of South Africa. Some argue that South Africa has a much stronger testing capacity, and perhaps that's a factor. However, in spite of limited testing in many other countries, the health system has not been overburdened, and the number of deaths remains low. So I'd like to ask each of our panelists to comment on the latest state of COVID-19 in the region, in your respective sort of context, including burden of infections, and your thoughts about factors that contribute to these disparities. And if I may start with Agnes, and the case of Rwanda, it's a population of about 12 million individuals. As of a week ago, approximately 4,700 infections and 27 deaths were reported. And yes, how has Rwanda managed to keep the caseload so low?
Thank you for the question, Fawzi. I think we simply follow the science. That's one. And we don't invent it, we contribute to the science. We all know what to do. And it's not, people will say, yes, with Ebola, etc., Africa has an advantage. No way. Ebola went in Spain, Ebola went also in the US, and you did the right thing then. So everything was known. We follow the science. Second, we absolutely study our contextual factors, those who are barrier and those who are advantage. Our advantage is, okay, strong leadership, an equitable based health system and service delivery, community health workers elected by the people, trusted by the people, and a communality in the message giving by the leadership. And a government work as one, meaning some region, people make it an issue of the Ministry of Health. No way. It's a Ministry of Health issue, education, internal security, transport, borders, commerce, local government, come together, do the best for the population and help implementing as one, based on science and the interest of each and every Rwandan. So that's how we have succeeded. And the example, lockdown, it was firm, but because we have a high percentage of people living below the poverty line, what we did, there was a budget to make sure that each and every family has can feed the family, has food on the table every day. You understand? So everybody can wait. People cannot afford the testing and the quarantine and the isolation. It was for free for everybody. So that people doesn't say, oh, I'm not going to pay the test because after that my family will bankrupt. No. Make a win-win situation for each citizen. If I contribute, I'm more safe and everybody is more safe.
That's very helpful. Thank you so much. Clearly, multi-sectoral response and leadership are critical lessons here. John, if I could turn to you, in an interview to BBC last week, you have attributed the low numbers in Africa to a joint continental effort that is supported by Africa CDC, focusing on scaling up testing, contact tracing, and wearing of masks. I wonder if you could elaborate a little bit on that, and particularly to what extent is the adoption of these three elements possible and actual by various countries? And is there enough data on the relationship between the level of adoption in certain countries and the caseload in those countries?
So thank you, Fawzi, for that intervention. I'm very pleased that, that Agnes also laid out some of those, what she calls applying the science and what is known to work to fighting the pandemic on the continent. And the virus is new. The methods are old. I mean, it's basic things you do in what you call shoe-leather epidemiology, and you do the testing, you do the tracing, and of course you do the isolation, quarantine, and you treat people or you manage the cases that and it has never been a controversy on the continent. I think there's a narrative out there that says that we have so many deaths out there that are not being reported, and that's why our numbers are low. I also said in that interview and subsequently on CNN that it's a false narrative. I think it's a narrative that is based on historical assumptions that we are poor, we are not equipped to do the right things, we don't have strong health systems, etc., etc. So all might be true, but it was never a controversy of using the whole of society approach, as Agnes mentioned, to fight this virus across the continent. Let me just say that, before I come back to that, say that the two of these, our panelists, are some of my heroes here, Salim and Agnes, because for Rwanda, those two countries, people say South Africa have 50% of the cases on the continent. And I said, that's true, but see what they have done, okay, twice. They've bent their curve twice. And that is good public health in action. The first time around, I'll let Salim, of course, speak to the South Africa, but let me speak on that from a high level, which is from a far away observing South Africa. So he applied what has to be done, especially engaging with the community extensively and doing the testing massively. There was no miracle there, other than they had to bend the curve, and they bent it twice. The second thing that we have to put out there as a continent is that the leadership at the country level across the board was strong and bold and courageous. To have locked down the economies for that long, I mean, it was painful for the government, but they did the right thing. They didn't choose to do the easy thing, but they did the right thing. And the right thing was going to be costly. If you look at the maps that we've plotted the data, and we see where countries were in March, they were all green. And then in April, May, they started turning orange, which means there was firm instructions or lockdown to stay home and implement other hard measures. By end of April and May, they had all turned red because it was firm. It was a firm lockdown across. Remember, countries are just now beginning to ease the lockdown across. South Africa, for example, is going to be opening up the borders only, I think this week or next week. So that is a lot of sacrifices there. And we have to factor this into the narrative when the outside world wants to characterize our situation as, well, maybe we don't know what has happened. We have not fully sized the epidemic, and we say no. I mean, because you can't neglect and ignore that strong leadership. When the first cases of COVID were reported in Egypt on 14th of February, on the 22nd of February, that is just 1 week, I remember on a continent of 1.2 billion, there were 2 cases in Egypt, and the leadership of the African Union convened a meeting of all ministers of health. And we rang a strong alarm, and we said, this is dangerous. We don't have the means that China has to fight this, build large-scale hospitals and do what it's doing, and Europe and United States. Let's take this seriously. I think the continent ran with that message. And if you recall, countries were locking down with 2 or 3 cases, right? They were declaring states of emergency, and people should never forget this. That was very painful for the continent, but they did that. And today, I think it helped to blunt the spread of the virus there. I think we should always remember that and not just characterize it generally like Africa is not testing enough. And we take our deaths very seriously. So if people were dying massively, we will all be attending funerals around and paying respect to our loved ones. It's not the case on the continent. So that's the way, that's what I meant in that interview with the BBC.
Yeah, no, thank you, John. And I mean, you echo and underscore the leadership again, not only at country level, but also at continental level. And frankly, African Union and Africa CDC as the arm of that institution, and yourself has been really sort of at the front right from the beginning. So that's highly commendable. So Salim, the big happening in news is South Africa, from the burden, but also from the response. As John has just mentioned, the burden is much less now. You've flattened the curve twice, he says. So would you share a little bit about that experience and what lessons we might sort of come up with for other countries? You're muted, Salim.
Thanks very much, Wafaie. It's a great pleasure and honor to be here with you, particularly with my two colleagues, John and Agnes. So when we had the first case on the 5th of March, and we watched what was happening in the first 10 days and the rapidity with which the epidemic was growing, within 10 days of the first case, we imposed a state of disaster, closed the schools, stopped international travels, prohibited gatherings. So action was taken very early. But over those first 3 weeks of the epidemic, the doubling time of the epidemic was 2 days. We were doubling every 2 days. And when we instituted the lockdown on the 27th of March, we slowed the transmission drastically to a doubling time of 15 days. So what was a growing epidemic, and we were almost neck and neck with the UK. If you plot our curve and you plot the UK curve, we were both going up in the same direction. Suddenly on the 27th of March, our epidemic turns and ours slows down. The UK just carries on up. So I think that what we were able to do is we were able to avert an early peak, because we would have seen a massive number of cases in April when we were not ready and we were just going to struggle and people were going to die. Instead, we slowed the transmission down at the community level. We could never achieve containment. We tried, but we knew that that was going to be a challenge. But when we eventually did get to our peak, which was in July, we were much better prepared. To give you some example, if you, called me from Harvard and said, can you please transform the Cape Town Convention Center into a field hospital with 600 beds, providing oxygen at every bed and 20 ICU full facilities, and can you please do all of that in 6 weeks? I'll tell you, are you crazy? Can anyone do that? Well, it was done. It was done. A fully fledged, functioning field hospital operating on the extreme other end of the continent. While the first cases were occurring in Cairo, this was being done in Cape Town. And I think it reflects the importance of being prepared, because we went through extensive planning to make sure we never ran out of oxygen. We redirected oxygen from commercial purposes to medical purposes. We created new storage facilities to make sure that every hospital never ran out of oxygen. We never ran out of oxygen once. So I think all of this indicates the importance of being prepared. And if you're prepared, I think that's part of the reason why our outcomes are not as severe as was expected.
That's great. Thank you, Salim. So on the point of what we can learn from South Africa, John, could you sort of reflect a little bit more on that? So one is preparing, and there has been a lot of preparations in various settings, but it's fortunate that the number of cases are low in many countries, unlike it is in South Africa. No evidence of collapsed health system as feared. But with respect to the adoption of these approaches that you have mentioned, the CDC, Africa CDC, have a good sense of how successful other countries are. Clearly, there are two examples here, Rwanda and South Africa. And what are what is the situation like in other parts of the region?
I think if, let me address that at a much higher level, which is closer to the region. The key word you use here is the regions. And we do this analysis every day at the Emergency Operations Center, pull the data, aggregate it, unpack it, and see country trends. But let me focus at a regional level and then go to some country levels then. If you look at it, all the regions, all with the exception of North Africa, are showing tendencies in the right direction. That is, over the last 4 weeks, we see decreases at varying levels from about 10% to about 17% across those 4 regions. That is Southern African region, Central Africa region, West Africa region, East Africa regions. North Africa continues to see increases, and that is driven by 2 or 3 countries there, Libya, Morocco, Libya and Morocco. I think Morocco is a unique example where they started off with a very timid line, and you could see that. And then, of course, I talked to Professor Marofi and Mohammed all the time on the leadership there, but somehow something happened, and you see that they are in this other upward direction there. So the point I want to make is that we have to look at Africa as a continent, but also know that we are a continent, not a country, and that there are specificities there. So, but if you take the regions, the 5 geographic regions of the continent, 4 of them seem to be in the right direction. But my caution to the continent is clear, that do not be complacent at all. We have seen and continue to watch what is going on in Europe with total dismay and total fears, because we've seen Europe gone down. And now we've seen over the last 3 weeks what is happening as countries ease the lockdown. So that is one. The United States, we saw what happened. At some point it went down and we were very optimistic. And then, so I think as countries ease the lockdown, we at the Africa CDC are adjusting strategies and also working with member states to make sure that there's uptake of that. For example, next week we'll be launching what we call Africa Against COVID-19, underpinned by saving lives, saving economies, and saving livelihoods, where we are saying that we need to do a couple of things: protect travel and borders, protect economies and businesses, and protect schools, okay? And take advantage of the availability of the new antigen test that is out there now to roll that out rapidly and massively so that we can scale up testing. I think just 2 days ago, I was on a press conference with Dr. Tedros and others, Peter Sands from Global Fund, and making that announcement. I think it's a very much welcome initiative. The PCR testing was always what I call a first generation tool to fight COVID. It was not the most suitable. A suitable test for our setting would be that a test that is affordable, is reliable, is scalable, and is easy to use. I mean, that the PCR test that has been the backbone in our response meets some of those criteria, but it's not enough to really provide that rapid turnaround time. So the countries, I say that because if you unpack the testing level, we've done remarkable work in scaling up testing. It started up with a tremendous challenge. We have pushed out testing. We set initial standards at around 10 million tests as part of the PAC initiative, the Partnership to Accelerate COVID Testing. We achieved and exceeded that. Today, as we speak, the continent has conducted about 15 million tests, and the test per case ratio is now about 10. So if you aggregate it, you always have to think of the aggregate numbers on the continent, but then disaggregate that by region and by country. So some countries are testing less, and some, of course, are doing it on the other side of it. But we hopefully, with the antigen testing combined with the PCR test, we will scale this up to, we hope that we'll achieve a new target of getting to 20 million tests by the end of October. Okay, and that is our determination from Africa CDC to push through this testing, of course, as part of the partnership. The reason I bring that explanation is that for us, when there were countries, when organizations were making projections as to how many people who died, I mean, we were very conservative on that. Africa CDC, we refused deliberately to issue out any projection. I look at the assumptions and I wasn't convinced. And I said, instead of trying to project how many soldiers are going to die in the battlefield, let's concentrate on arming the soldiers to go fight the fight. That was my philosophy, and which we adopted, and we refused to issue any projections at all, because it was not going to help us. It could be defeating. If truly the assumptions were solid and we knew that 3 billion people were going to die by this time, I think probably I would have just said, well, there's no way we are going to win this war. But we were focused on rolling out diagnostics, and that is exactly what we did.
That's wonderful. Thank you, John. Agnes, with sort of the great response in Rwanda, a key point that John has just emphasized is not to be complacent. The number of cases are low, the number of deaths are low. There is a natural and a human tendency to kind of relax some of the approaches. How do you manage to maintain that level of kind of vigilance that enables it to remain as low as it is? Sorry, you may be muted.
Yeah, I was on mute, sorry, Wafaie. So this is a great question. And let me tell you how the fight is managed in my country. There is a cabinet meeting, minimum every 2 weeks. When there is a threat like this, at the peak of the moment where the country was stressed, every week, subject number 1, COVID response and preparedness, under the leadership of the president. And of course, the president is guided by our scientific people who bring to the table the last knowledge, because we know every day new things with this new, with this pandemic. We learn, or you bring also the people in charge of economy, because there is a balance there. The country needs to survive and the people need to be safe. And they decide what to do. And those are cabinet instructions. And because we are lucky to have a leadership that trusts science, that help the implementation arm of the government to implement what should be, it works. And the president is the first person to say, so far we are managing, but please don't relax. We trust, we do. And also we know that it's something to do. The second thing is we have reopened the country, but slowly by slowly. And we are ready to say, the high level instructions say, we will evaluate again in 2 weeks. And sometimes we evaluate after 4 days. Like when we reopened the market, there was a peak, shut down the market and study how entry and get out of the market and user marks can be better managed. Now it's open again. Next week, we are going to open the school. Everybody is on alert because the kids are the kids, you know. Go and say social distancing. I love these jokes. The mom asked to the child, but it's not the mask I gave you this morning. And say, oh, no, I changed it with George because the one of George was more beautiful. He just get it from Iron before because the one of Iron, etc. Kids are kids. So we are expecting a peak. If it's too much, we will roll back and see what we can adapt. To every situation, there is a solution. We need to find, first of all, what the situation will be and adapt the situation. But we also know, everybody knows, social distancing is non-negotiable. Mask out of the house is not negotiable. Mask when we have visitors, please respect it. And also the classes will resume, but less crowded than before, because they will respect the fact that in any volume of space, you can only use it 30% of it. So the Minister of Education is thinking with his staff how to make it possible. Rwanda has built a lot of school classes to respond to COVID, recruit more teachers to respond to COVID. But we don't know what it will bring, and we are just ready and in alert.
That's great. So clearly, a lot of success in South Africa, in Rwanda, in many countries. And maybe a question to you, Salim. These successes need to be celebrated and acknowledged, and we shouldn't fall prey to the sentiments that John was referring to earlier, that sometimes is in the Western media that, well, one expects sort of poor outcomes out of Africa. It reinforces a certain image that one has. But in spite of the successes that we see, there are many challenges. And the number of cases that we see are far lower than what we would have expected, perhaps for other reasons. There are other explanations, maybe, some posit. And I wonder, you had some hypotheses and factors that might sort of begin to shed some light on these, not to undermine or underestimate the success that has been put forth, but to sort of be aware of these and not attribute all the low caseload to the response, because some countries are underprepared even today. So your perspective, Salim, on that.
Yes, sure. When I think about, when the modeling was done very early on in March, and I was looking at the way the numbers were turning out, I have to say I was somewhat skeptical. And it's always, one always needs to treat mathematics with lots of assumptions, with a healthy dose of skepticism. When I reflect now on what has actually occurred, for me, one of the biggest challenges we have been grappling with is the issue that to deal with this epidemic, we knew we had to take government action urgently. So we couldn't, even a week in this epidemic, you can lose and the virus gets ahead of you. So early government action was critical. But that meant that we were, as a government, taking charge of and controlling people's behavior. That's not sustainable in any kind of way. And so we needed to pivot the prevention paradigm away from government action, institutional authority, to individual authority, to individual agency, that I can control my risk of getting COVID. I can control whether I social distance, whether I wear a mask, whether I sanitize my hands. So that kind of pivoting from initial government action, which caused anxiety and people were scared, to one where we wanted people to take agency, to act on their own behest, was a big challenge to shift that paradigm. And now we're trying to shift that paradigm one step further. Now we want people not to just take individual agency, but we want them to fundamentally understand their interdependence. That I am safe because you are safe. Now in a country like South Africa, President Nelson Mandela built our society on the concept of Ubuntu. Ubuntu meaning, I am because of my community, and people are fundamentally contextual. Now we're trying to get people to follow that basic paradigm. We want to shift initially from government action to individual action. Now we want to shift to collective action. We want people to be protected in their communities for communal benefit, and understanding that any person who breaks the rules and decides to not follow the prevention rules is not only putting themselves at risk, but putting their families, their work colleagues, the transport colleagues, putting whole communities at risk. That has been a challenge for us to move and to undertake that shift in that kind of way. Against that backdrop, when I look at how the epidemic has unfolded in much of Africa, we are seeing fewer cases than we anticipated. We are seeing fewer deaths than we anticipated. And it's not a question of that we are somehow hiding the deaths under the beds or, somewhere. You can't hide this epidemic. The people pitch up at the hospitals with respiratory distress. My colleagues from across the continent are telling me they're not seeing, queues of patients coming in with respiratory distress. So it's not that there's an epidemic out there that's simply not being documented or being hidden. There is underreporting. That goes without saying. This is an epidemic that half of the cases or even more are just asymptomatic. So there will be underreporting. There is undertesting. That is the case in pretty much every country. So those are features of our epidemic that are common to many other places as well. But what is the uniqueness that we have? I believe that one of them is our youth dividend. Our younger populations give us the opportunity so that fewer cases are occurring in older people where the disease is severe. And so I think younger populations are part and parcel of the answer. But even younger populations don't fully explain what we are seeing. There has to be other reasons. I think one of the other reasons is a combination of the fact that we perhaps do not have the high level of international travel that you see in London or in Paris. And because we locked down early, and countries across Africa locked down early and banned international travel early, we were able to slow the introduction. And so this epidemic was seeded to a lesser degree. Combine that with fewer people moving as a result of the lockdown, you create better conditions for initial control. But there are also many other hypotheses. My colleague, I made a list of 9 hypotheses. Some people tell me, it's the hot weather in Africa. I said, well, you have to know the epidemic was spreading in the summer of Europe. It spreads in the heat of India. So it's not scared of a little bit of weather. It will still spread. Some people tell me it's altitude. Others tell me, poor people have got the common coronavirus that causes colds, and so that's protecting them. I said, if that's the case, why are the favelas of Brazil in the midst of a massive epidemic? Why is Delhi, with such high coverage exposure rates? So even if it is true, it can't really explain the majority of the effect. I think it's a combination of things that came together. And I think it combines the youthful population, the travel patterns, the early action, and then I think ultimately the level of response that was put into gear, that we didn't have people cross-talking. We didn't have one person saying this and the president saying something else, as we've seen in several other countries. Here, there's a consistent message. The politicians have acted early. There's no benefit for politicians to lock down. That's affecting their own countries. They do it because they are committed to seeing the process of saving lives. And I think that's what was important.
That's helpful. Thanks, Salim. And yes?
Yes, I want to jump in with a more radical opinion. What Salim said is totally true. We stopped the flight immediately. We stopped saying nonsense immediately. CDC called all our ministers of health immediately, and they prepared the continent immediately. So the people who want to find excuses, it's just because they don't like that Africa is doing better than the Western world. I saw people say, oh, it's because they're Black and they are genetically protected. Why the Black people are dying more in America? They're genetically like us. Just grandchild of slave of my brothers and sisters. They are young. Okay. Why they are the part of the world where there are young people that are not behaving like that? So let's face the reality. Africa is not the black box as usual. Africa is full of resources. Africa did well because of what we use, what we had, and we follow the science. Nonsense. Look at the country where they say nonsenses. They have the same problem being in Africa. And also go and see what countries like Vietnam did well, the same. So if the world doesn't tackle what Africa did well to be where we are with the little we have compared to the Western world, the world will not take the right actions. Recognize that we did good. You don't like it, but it's the truth.
Well said, and yes, thank you so much. Thanks, Slim, for that. And I see John smiling, so I'm sure you are completely in agreement with that. So if we could move on to another segment, if I may, and I'd like to talk a little bit about vaccines in Africa. There was a lockdown in many places, most places, the lockdown is being eased, and it's really, admittedly, right from the outset, a temporary response to enable other measures to be put in place to prevent and control infections. And one of that is vaccines. There is a lot of optimism that the global community is closer to identifying at least one safe and efficacious vaccine for COVID-19. Expected perhaps later this year or early next year. But many people are worried that Africa will be left at the back of the queue for accessing that vaccine. And that has been the case in the past. If one reflects on antiretroviral therapy, it has been available in the US and other settings long before it was available at an affordable rate and quantity to many Africans. And in the interim, millions of people have died. So vaccine nationalism is on the rise. Clearly, more developed settings have cornered a large amount of the vaccines that are in the pipeline. It's in a recent report, 50% of promised doses have been already committed to 13% of the world population in Europe and the US. Another recent report said from Oxfam, about 60% of the global population is unlikely to have a vaccine until at least 2022. So, John, if I could ask you, are these worries justified? Are there ways that we can, as a global community and as a continent, sort of make sure that Africa is not left behind in the quest for these vaccines?
So thank you, Wafaie, for the vaccine question, which is, in my view, the greatest geopolitical discourse that is going on. And I want to assure the audience that Africa is working very hard collectively, as Slim mentioned, to ensure that we are not left behind. The story about ARV and the history, and I can see that the four of us participating in this dialogue were all part of, actively engaged in HIV research when antiretroviral therapy was available in 1996. And then if you look at it, the curves, in 1997, we started seeing drastic decrease in deaths in the United States and Europe. But it would take 10 years, up to 2005, before you saw our own curve come down. And between 1996 and 2005, 12 million Africans died. I engaged with the UNAIDS the other day, and I said, give me all the data of people who died from HIV/AIDS between that period. And they gave me, and I presented to our leadership. And just before this meeting, I was presenting that same data to our permanent representative committee of the African Union, and they are meeting today, and we had an all-day meeting today and tomorrow, and then they will present that to the Executive Council and to the head of states. So a couple of things the continent is doing. One is we've now developed from a consultation that we had with Salim and others on 24th of June under the leadership of President Cyril Ramaphosa, in his capacity as the chair of the African Union, convened a very important meeting that we discussed all of this and then develop a strategy based on 3 pillars. One is We must participate in clinical trials, and I'll let Salim comment on that if you want. Second is to get engaged with the procurement and financing. And I'm in discussion again with the envoys, that economic envoys that were appointed by President Cyril Ramaphosa as special AU envoys to work and support me to find the resources to procure the vaccines, including banks, the Afri-Exim Bank and the African Development Bank, who will engage with them. And so that discussion is active. I can say that I spend nearly all my evenings either with a Gavi or with a CEPI or with WHO and these special envoys and vaccine manufacturers. I mean, just discussing and very hard, I mean, courageous discussion as to why do you think the 220 million doses that the WHO is saying they will allocate to the continent is enough. I think that is just, we are saying we need more than that. And we need it now. Okay, when everybody else is getting their shots, we want to get the shots at the same time like anybody else. I think that is, rest assured that we are very vocal with that. We have a plan for that. And then the third pillar is to say, if vaccines were here today, what should countries be doing to roll out vaccines in a timely fashion? So we are working on that aggressively. We call it the preparedness committee. So I think Salim and Professor Sambaso from Mali are co-chairing the first pillar, which is the clinical trials piece, and I think I'll let him comment on that. So the continent is moving on that. We are actually at a point where this week on the 7th of October, the special envoys, myself and Stripe Masiwa will be meeting with the chair of the African Union, Chairperson Moussa Faki, to discuss a comprehensive package that we think we can propose and offer to the continent. That way we have two avenues to access vaccines, either through COVAX or directly. Just last night, we had a long discussion with the Oxford group, and they have, as you know, contracted some of the manufacturing to the Serum Institute in India. And as I speak, as we're on this call, an email just came in that is going to introduce us to the Serum Institute, and we engage with them. So we are not going to go to the table with a basket just begging for people to help us to secure our future. We are going to go to the table strong and say, look, we are going to put together a package, a financing package of about $4 to $5 billion to really have a proper seat at the table, and not just take a seat that would say that we'll get the remains. We shouldn't be a remains, a continent of remains. So I think that is what I'm learning from the history. When I say this, people say, okay, yeah, there was another vaccine that Africa got access to. I said that 1996, I was already a senior. I mean, and I was up to 2000. And that's the first time I saw Salim struggling with the AIDS conference in Durban, where access to ARV was a big issue. And I think I sat in that room and I felt sorry for him because so I think that just to come,
go ahead.
That the continent learned a lot from that. And I think I want to say that history should not repeat itself.
That's very helpful. Thank you so much, John. It's really encouraging to see all the effort that's in the background to ensure that vaccines are available to Africans. You maybe we'll come to sort of trials in a little bit, Slim, but maybe helpful to hear from you and yes, on the issue of rollout. There are at least two major challenges that are referred to for sort of, should the vaccine become available in adequate numbers, thanks to all the efforts that John has mentioned. There are major infrastructural concerns about making it available. There might be need for a cold chain. We are not sure whether that's the case or not. There is insecurity and transport issues that have to be dealt with. But then there is also a second sort of constraint that is emerging strongly in many circles around vaccine denialism, misinformation, and conspiracy theories. That's quite prevalent in the US, but making its way in Africa as well. So perhaps Slim and then Agnes, your take on how countries on the continent are prepared to roll out that vaccine as soon as it is available.
Yes, I mean, we're really grappling with this problem. So the South African government set up a committee on which I serve amongst others, chaired by Professor Shu, to really grapple with this issue. Should we be part of COVAX? The answer was yes. Now, how do we prioritize and how do we ensure we can actually implement this program rapidly? It's one thing to get enough doses for 10% of the population. How do you get it to the right 10%? And we're prioritizing, groups such as healthcare workers, such as the elderly, such as those with comorbidities. But this is not a vaccine that you just simply, add it to your usual EPI schedule, that's given in the clinics by the nurses to the little kids. This needs a whole new way of delivering this vaccine and how to do that. And so that's the logistics of what is busy being planned right now, because we need to start working on that now because of the complexity of what that's going to involve. But I want to add that we are facing in South Africa a growing and quite a vocal community of anti-vaxxers. And somehow social media seems to be a major haven for these kinds of individuals. And they go on the attack or, trying to undermine our efforts. I mean, for example, I come under attack for being associated with Bill Gates. Like that's, some bad thing to be because it's seen as anti-vaxxer. So I think that's a growing problem in our country. We don't have a simple solution to it. But one of the things we do have is a very consistent message, because we've been through denialism. We have been through a situation where the state held us back. We're not going to go through a situation where a bunch of people with their own weird ideas is going to hold us back now. So that plan is already in place. But to make that a reality, that we actually will have vaccines, we also are looking at developing manufacturing capacity. Now, that might not be something in the short term, but we have to think about the coronavirus as not a sprint, but a marathon. And as we think about it like that, we need to be able to manufacture. And we're fortunate in South Africa, we do have a facility that's largely funded by the state that can do that. And that's part and parcel of our plans to look at how that facility can play a role. So it's on multiple, making vaccines, fighting the anti-vaxxers, establishing the processes for making good decisions about who should get it, putting in place the logistics to get it out there. I'll stop there and I'll hand over to Agnes.
Thanks, Slim. And yes, you served as Minister of Health, so you have dealt with many such issues. Any insights into how this will come?
Yes, and I was a very proud one. We have seen that there was a study done in 2019 by Wellcome Trust about vaccine. First of all, understand that in everything that John and Salim said are true. I'm just building on it. So I'm not going back to that. If the vaccine is there next month, Rwanda will be ready right away to implement it. We have the best kid vaccinated on us. 11 antigen for the boys, 12 for the girls, with the respect of the cold chain and international praise for how we manage the stock, the procurement, the delivery, the control of side effects, etc. One vaccine more than that. What is it, Wafaie? Nothing. And we have a population who trusts the leaders. That's why we have this number. When I say 90% of our kids vaccinated, it's fully for each of the antigen, the number of injection needed. Some it's 2, some is 1, it depends. So we are ready. It's not rocket science to plan for a cold chain. It's just if a country can land and let plane take off, they are not crashing in the air, they can deliver vaccine. Put your Institute of Statistics to know the numbers, put your health professional to know who can deliver, and make sure that the authorities in charge of the electricity to respect the cold chain are working when you need them. And after that, buy the needed space in the cold chain. After that also, make sure not to buy too much and manage. You have muzzles given there, so you can buy, you have this much space. It's logistics. Totally neglected by some countries and lose a lot, but it's simple. So for our vaccine, we are ready to have now 12 for boys and 13 for girls. We are ready. The fact also to say that Africa, it's the same narrative that we are not going to be sure that they should be served because they will not absorb, etc. No way. Promise the vaccine, African, like Salim says, there is a good pushing to make it happen. Africa will make it happen.
That's great. Very, very encouraging. Salim, perhaps a minute if we are coming to the end of time, and just perhaps if you could comment for very briefly and then pass the last word to John on trials and production and participation in development of vaccines. Africa has been very behind on this in general. It's estimated that 2% of clinical trials globally of all vaccines take place in Africa. Of about 33 COVID vaccine candidates that are under evaluation, it's estimated that 2 are enrolling Africans, perhaps in South Africa. There is some work on vaccine research in Egypt, but really very limited otherwise on the rest of the continent, in spite of capacity from prior trials, from meningitis to malaria and infrastructure that's out there. What's the reason for that, and what's the way forward?
Yes, I have to say it was disappointing to see that many of the companies that were involved in vaccine manufacturing didn't look to Africa. And I think part of that was that the epidemic came late to our continent. And so they didn't get a sense that there was good enough epidemiology and understanding about which populations we could enroll. But thanks to the leadership of John and the AU Secretariat, we now have a specific drive where clinical trial sites throughout Africa, who have a track record for having done FDA or EMA regulatory trials under the regulatory submission, have been brought together under the umbrella of the African CDC to create a joint initiative. And with that, we have gone to individual manufacturers, we have gone to the WHO, and we've entered into discussions and negotiations so that we can increase the number of COVID vaccine trials that we are undertaking. I think it's important to note we have a pretty good understanding of the phylogenetics of the virus. So that's not an issue. In terms of vaccines, we know which vaccines will work and which won't. Currently, our spike protein is very stable over several months. So any of the vaccines currently manufactured should be effective in our setting. We have a good understanding of the epidemiology in many of our clinical trial sites. And importantly, we know how to do GCP level trials. I think doing the matchmaking between the developers and the clinical trialists has been the missing link. And the Africa CDC is now taking on that challenge and being the matchmaker to get it all in place. And I'm hoping that we will succeed.
Great. So John, you are a matchmaker, clearly on many issues. from testing to other approaches, but also on vaccines. Sort of last word from you, John, and Africa CDC perspective on sort of the next steps on vaccines and sort of broader perspective and thoughts on what can sort of listeners and others who will watch the video later on kind of do to support Africa CDC in advancing its mission.
So thank you so much. I think one of the things that, let me use my few seconds and address 3 points. One is that the COVID-19 pandemic has underscored the whole concept of global health, which is underpinned by inequities, vulnerabilities, and connectivities. I think that is just basic. I mean, there's no more to be said on what COVID has done than that. I think it has flattened, not only have we are trying to flatten the curve, but it has also flattened the world. If you look at all those global health indexes that the nice maps that were published all the time with some countries green and some red, this pandemic has shown that those were games, numbers, that you put out the numbers there, and then of course the results, you color some. I mean, so it means we have to work together. It means the virus has shown us how it can divide us, but it has also shown us how it can unite us. I think that, let me build on the uniting piece there. I think my sister Agnes is here, Salim and I have worked together for HIV for long. We are now united as what I call unity of purpose as a continent. It has never, in my 32 years in public, have seen the continent come together in this manner, where all its expertise have been harnessed and continue to be harnessed to, I mean, across the board. Every 2 weeks, the steering committee of the task force comes together and brings all the best minds on the continent. So that's segues to number 2. The second point is that no one should confuse the difference between limited resources and the capacity on the continent. We may not have the funds and limited resources here, to be very specific, is the funding, but we have abundant, capable capacity on the continent. Let there be no doubt. Just look at the 2 people on this call, on this panel, have done trials, have managed programs, and they are very capable, I think, of doing that. So if the world's narrative doesn't look at that and only focus on the historical narrative of the continent, then I think it will be a big mistake. My last comment is about Africa itself, to take our own destiny in our hands and say, look, we are seriously challenged as a continent in 3 dimensions if we have to ensure the health security of our continent. One is in the area of manufacturing diagnostics. Second, in the areas of drugs, manufacturing drugs locally. And then thirdly, in the areas of vaccine development. And we should really say, never again should it be that in the next pandemic, we are relying entirely 100% on externalities to guarantee our own future. That means we will be, as Africa CDC, proposing to the leadership of our continent that there should be a new public health order. That says we commit our own resources internally to developing centers and hubs of innovation, because you can't do any of those 3 without research and innovation that will lead to development of diagnostics, development of vaccines and drugs across the continent. We should move away from that narrative that says, oh, it's so difficult to manufacture drugs in Africa. It's so difficult to manufacture vaccines. And look at what COVID has done. There are now 5 countries that are manufacturing diagnostics for COVID locally. Senegal, Kenya, Nigeria, Morocco, South Africa. Before, none of them were doing that. So I think I'll leave you with those 3 points. Thank you.
Thank you so much, John. This is very helpful. And this has been a wonderful session. Sorry, we didn't have a chance to get to some of the questions in the Q&A, but you ended on a point that you underscore regularly, and it's exciting, really. And that is how united approach is really a critical part and a central element of this process. John, you have been recently quoted, you have recently quoted President Kwame Nkrumah, first president of Ghana, in saying, "It is clear we must find an African solution to our problems. and this can only be found in African unity. As many countries turn inwards to protect their own populations, Africa provides valuable lessons to the rest of the world in the way it has been handling the pandemic. That central core element of unity has been coming throughout the session today and over the past few months. Thanks to the leadership of Africa CDC, to the member states, to African scientists like all of you. So thank you so much again, Agnes and Slim and John. Thanks to the participants. As I said, this is recorded and we will post it on our website and make sure it's available for people to view at later times. Thank you so much.
Thank you. Thank you. Bye-bye.
Thank you very much. Bye.